Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today, we're tackling a really critical topic, something that demands immediate action. The Perforated Duodenal Ulcer, PDU.
Absolutely. A true surgical emergency.
And for you, our listeners, clinicians, surgeons, we know that in these situations, every single minute counts. So we're aiming to give you a sharp, focused guide.
That's the plan. We want to dive into the latest on PDU, from spotting it to managing it, give you those essential insights drawn straight from the source material.
Think of it as a targeted refresher for when things get intense. But first, and this is really important, we have to state, this deep dive is purely for educational purposes.
Yes, critical point.
It's here to supplement your knowledge, not replace it. You must always follow your local guidelines, your hospital protocols, and crucially, use your own expert clinical judgment when caring for patients.
Couldn't agree more. This enhances, it doesn't override. Your assessment, your protocols, those are paramount.
Okay, right. Let's get into it. PDU is a life-threatening complication of peptic ulcer disease.
Yeah.
When that patient hits the emergency department, what are we looking for? What screams PDU?
Well, the absolute cornerstone is maintaining a high index of suspicion. You can't afford to wait and see with this one.
Right.
The classic history, it's often quite dramatic. Patients typically report a sudden, really severe epigastric pain. They might describe it as tearing.
That sounds intense.
It is, and it doesn't stay localized. It rapidly spreads across the whole abdomen as, gastric contents leak out.
The dreaded generalized peritonitis.
Exactly. And many patients will say it's the worst pain of my life. You also often get that referred pain to the shoulders.
The diaphragmatic irritation signal.
Precisely, from the free air and chemical irritation under the diaphragm. Now, here's a key thing. While many do have a history of PU, maybe dyspepsia, up to maybe 25% of these perforations happen out of the blue with no prior symptoms.
Wow, a quarter of them. That's significant. That could really throw you off if you're relying solely on a history of indigestion.
It absolutely can. So you always need to ask about risk factors, NSAID use, steroids, smoking, alcohol, and, of course, H. pylori infection lurking in the background.
And systemic symptoms. What follows the pain?
Often nausea, vomiting, loss of appetite. And as the peritonitis really sets in, you start seeing signs of sepsis developing. Tachycardia, maybe a fever later on, signs of shock.
Okay, so the history is painting a pretty urgent picture. What about when you examine the patient? What are the physical findings you expect?
You'll usually see someone who looks acutely unwell. They're anxious, maybe sweaty, pale, tachycardic. Fever might be absent early on, don't forget.
Right.
But the abdomen, that's where the classic signs are. You get that board-like rigidity. It's involuntary guarding. The muscles are rock hard, extreme tenderness everywhere, and profound rebound tenderness.
That involuntary guarding is such a strong indicator of peritoneal irritation.
It really is. And typically, if you listen with the stethoscope, the abdomen's silent. There's an ileus because the bowel just stops working.
Any other specific signs we should look for?
Well, there's the loss of liver dullness on percussion. Tapping over the liver area, instead of dullness, you might get resonance because there's free air trapped between the liver and the abdominal wall. It's specific if you find it, but not super sensitive.
Okay, so helpful if present, but its absence doesn't rule PDU out.
Exactly. And a digital rectal exam might reveal some tenderness down in the pelvis and the rectovesical pouch, suggesting fluid collection there.
Got it. So clinical picture is strongly suggestive. Now, investigations. What are the absolute must-dos to nail the diagnosis and plan the next steps?
Okay. Investigations need to be quick. Bloods first, you'll likely see a raised white cell count, leukocytosis. Check UNEs, amylase, lipase. Amylase can be a bit tricky. Well, it can be slightly elevated in PDU, just from irritation, so it doesn't definitively rule out pancreatitis, but very high levels obviously point more towards pancreatitis. Lactate and a blood gas are vital. They tell you about perfusion, acidosis, septic shock development.
And prepping for the inevitable.
Absolutely. Group and save, or cross-match blood, essential before any potential surgery.
Right. And imaging, that's key here, isn't it?
It is. Imaging is really the diagnostic cornerstone for confirming the perforation, specifically the free air. The first-line test is usually an erect chest x-ray.
Why erect?
Because air rises. So if the patient sits or stands up, any free air in the abdomen will collect under the diaphragm, and you can see it as crescents of blackness on the CXR. It picks it up in maybe 70, 80% of cases.
And if they can't sit up, too unwell.
Good point. Then a left lateral decubitus X-ray of the abdomen is the alternative. The patient lies on their left side and air collects over the liver against the right side of the abdominal wall.
Okay, so CXR first. But what if it's negative or unclear, but you're still really suspicious?
That's where the CT scan comes in. A CT of the abdomen and pelvis, ideally with both IV and oral contrast, is the gold standard. It's incredibly sensitive, like 98% sensitive for pneumoperitoneum.
So much better than the X-ray.
Oh, definitely. Plus, it doesn't just confirm the diagnosis, it can pinpoint the location of the perforation, see if it's contained, and crucially rule out other serious conditions if the diagnosis isn't clear-cut.
Which brings us neatly to differentials. The acute abdomen, it can mimic so many things. Once PDU is high on the list, what else are we urgently trying to exclude?
Yeah, you have to think broadly. The presentation can overlap significantly. Obviously, a perforated gastric ulcer presents almost identically, though the exact surgical approach might differ slightly.
Okay, what else?
Acute pancreatitis is a big one. Epigastric pain, often radiating to the back. High amylosylipase CT usually sorts that out. Acute cholecystitis, think RUQ pain, Murphy's sign, ultrasound helps there.
Appendicitis, could that be confused?
Early on, maybe, before the pain fully localizes to the right lower quadrant, especially if it perforates early. But then there are the real can't-miss diagnoses.
What?
Like a ruptured AAA abdominal aortic aneurysm. That's a catastrophe. Pain, maybe hypotension, sometimes a pulsatile mass. You cannot miss that. Mesenteric ischemia is another often presenting with pain that seems way out of proportion to the physical findings.
That pain out of proportion is a classic red flag.
It is. And never, ever forget a heart attack, particularly an inferior MI. It can cause epigastric pain and nausea. Always get an ECG in patients with significant upper abdominal pain.
Excellent point. Okay, so diagnosis is confirmed or suspicion is sky high, differentials considered. The clock is ticking furiously now. What's the immediate game plan? Time is tissue, time is life here.
Absolutely. And the immediate priority before anything else is resuscitation. ABCs, airway, breathing, circulation.
Standard emergency approach.
Yes, but it needs to be aggressive here. High flow oxygen. Get 2 large bore IV lines in immediately. Start pumping in crystalloid fluids, Hartmann's, normal saline you need to restore volume fast. Aim for good urine output over 0.5 mils per kilo per hour.
What about pain and other supports?
Pain relief is vital. Morphine, or another strong opioid. Don't withhold it for fear of masking signs. The diagnosis is usually clear by now. Give antiemetics like ondansetron for nausea. Monitor them closely. Continuous pulse ox, ECG, blood pressure. If they're unstable, an arterial line is a good idea for real-time BP monitoring and blood gas sampling.
And antibiotics. Sepsis is a huge risk.
Crucial. Broad-spectrum IV antibiotics right away. You need to cover gut organisms, gram-negatives, anaerobes, something like piperacillin tazobactam, or maybe a combination like cefuroximab metronidazole. Follow local guidelines, of course.
Okay, and the NG tube?
Yes. Pass a nasogastric tube, decompress the stomach, suck out residual contents. It helps reduce ongoing peritoneal contamination.
Right, resuscitation rolling. Now, definitive management surgery is usually needed, right? What are the options in the OR?
For most free perforations, yes, surgery is the mainstay. The goals are simple. Stop the leak, clean up the contamination.
And the standard procedure now?
The procedure of choice for stable patients and where the expertise exists is a laparoscopic omental patch repair, the Graham patch.
Laparoscopic, minimally invasive, what are the benefits?
Exactly. Less post-op pain, quicker recovery, smaller scars, potentially fewer wound complications compared to open surgery. You find the hole, you plug it with a piece of healthy vascularized omentum like putting a patch on a tire and suture it in place. Then, importantly, you wash out the entire peritoneal cavity thoroughly with liters of warm saline.
Okay, so lap repair is preferred. When would you do an open operation?
You'd go for open surgery if the patient is too unstable, if they have severe adhesions from previous surgeries making laparoscopy difficult or dangerous, or simply if laparoscopic expertise isn't readily available. The principles are the same. Find the hole, patch it, wash everything out just through a midline laparotomy incision.
What about those older operations? The definitive acid-reducing procedures like vagotomy. Do they still have a role?
That's a really interesting point, showing how much things have changed. The answer is rarely. Almost never, actually.
Why the shift?
Because our medical treatments are so effective now. Proton pump inhibitors, PPIs, are brilliant at reducing acid, and we now know the crucial role of H. pylori and can eradicate it. So routine acid-reducing surgery isn't necessary for most uncomplicated perforations.
Are there any indications left for it?
Very few. Maybe if medical therapy has repeatedly failed before the perforation, or if it's a giant ulcer, say over 2 centimeters, or if there's also significant scarring causing obstruction, or if you strongly suspect the patient absolutely won't comply with medication afterwards. But these are exceptions.
Fascinating shift. Now, what about not operating? Is non-operative management ever an option?
NOM. Non-operative management. It's controversial and suitable only for a very highly selected group.
What kind of patient are we talking about?
Someone who is hemodynamically stable, has no signs of generalized peritonitis, and where the CT scan clearly shows the perforation is contained, maybe already sealed off, with minimal contamination.
And what does NO involve?
Strict nil by mouth, aggressive IV fluids, high-dose IV PPIs, IV antibiotics, and really close monitoring, usually in an ICU or high-dependency setting. Any sign of deterioration, worsening pain, fever, rising inflammatory markers means immediate surgery.
Sounds risky.
It carries a significant risk of failure, developing an abscess, or delayed sepsis. It is absolutely not the standard of care for the typical PDU patient presenting with peritonitis. It's reserved for rare, specific circumstances. Surgery remains the standard.
Okay, so surgery's done, or NOM is underway for that select few. The immediate fire is out. What's the focus post-operatively and for the long haul? How do we stop this happening again?
Right. The focus shifts from immediate crisis to recovery and prevention. Post-op, patients often need continued support, maybe in ICU or HDU, especially if they were very septic. We continue the IV PPIs to help the ulcer heal, continue IV antibiotics for a few days, usually 3 to 5, depending on progress and local protocols.
When can they eat?
The NG tube comes out once the gut starts working again, bowel sounds return, passing flatus. Then you gradually reintroduce diet.
And the crucial long-term stuff.
This is key for prevention. Number 1, test for and eradicate H. pylori. This is mandatory. Use a urea breath test or stool antigen test, but remember to stop the PPIs for about 2 weeks beforehand for accuracy. Getting rid of H. pylori massively cuts the recurrence risk.
Okay, H. pylori eradication is non-negotiable. What else?
Stop the NSAIs. That's critical. If they absolutely need an anti-inflammatory, you might consider a COX-2 selective inhibitor, but always with ongoing PPI cover.
Lifestyle factors.
Yes. Counsel them strongly on quitting smoking and reducing alcohol intake. Both are bad news for ulcers, and often long-term PPI therapy is needed anyway, especially if they had to restart NSAIDs or if they were H. pylori negative to begin with.
So putting it all together, the rapid diagnosis, the resuscitation, the surgery, the long-term prevention. What does this mean for outcomes? What's the prognosis?
Well, it varies hugely, and it really highlights the importance of speed. For a young, fit patient who gets to surgery quickly, mortality can be as low as, say, 1 to 3%.
That's pretty good, considering.
It is. But for an elderly patient, someone with lots of other health problems, or someone who presents late, maybe more than 24 hours after the perforation, the mortality rate skyrockets. It can be over 30%.
30%.
Yeah, it underscores the point. Early diagnosis and prompt, effective intervention are absolutely the most critical factors determining whether the patient survives and recovers well. Time is everything.
Absolutely. So we've covered a lot from that sudden severe pain and the diagnostic pathway through the mimics we need to exclude, the critical resuscitation steps, the surgical options like the Graham patch, and finally that vital post-op and long-term care focused on H. pylori and NSAIDs. Hopefully this gives you a really solid, actionable overview.
I think it does. It really emphasizes that PDU isn't just about the surgical technique. It's about rapid assessment, decisive action, good resuscitation, and strong multidisciplinary teamwork. And maybe it leaves us thinking, how can we better identify those patients before they perforate, especially that 25% without prior symptoms? That remains a challenge.
A crucial question indeed. And just one final time, a reminder to all our listeners, this discussion was for educational purposes. Your clinical practice must always be guided by your local protocols, institutional guidelines, and your own professional judgment.
Absolutely. Stay updated, stay vigilant.
Stay sharp, keep learning, and thank you for joining us on the Deep Dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.